Good afternoon, everyone. I'd like to acknowledge that today is World Elder Abuse Awareness Day. And as Dr. Catherine Barrett posted earlier today, we need to continue the work of ending elder abuse so that this day is not needed in the future. This year, Elder Abuse Action Australia and CODA Tasmania are hosting 3 forums that will lead into the 7th National Elder Abuse Conference next February in Hobart. I'm delighted to welcome you to the second of the Walk the Talk Forum series, Driving Long-Term Change, Australia's Response to Elder Abuse. My name is Bev Lang and I'm the Executive Officer at Elder Abuse Action Australia, or EAAA. I'd like to acknowledge and pay my respects to the traditional and original owners of the Darkinjung land which I'm on today. And I'd like to also pay my respects and acknowledge the lands on which our speakers today are on. Always was, always will be Aboriginal land. EAAA and COTA Tasmania are co-hosting this forum and next year's conference, assisted by our expert cross-sectorial program committee and events managers, Nectar Creative Communications. In many ways, the Walk the Talk Forum series was born out of COVID-19 because next year's Elder Abuse Conference was meant to be in February this year. When the pandemic happened, we knew we would have to postpone it, but were determined to keep the faith with delegates from previous conferences and other frontline professionals and academics and researchers who were keen for this conference to proceed. And to also engage new audiences by organising a series of forums like this particular one. Walk the Talk Forum 2 will discuss what Australia has achieved and what more must be done to end elder abuse. The issues and insights raised will be the basis for further discussion during the conference on the 14th and 15th of February 2022. And we're also looking to have a post-conference workshop, community workshop on the 16th of February. Our speakers today are Russell Westicott, the EAAA co-chair, Sue Leach, CEO of CODA Tasmania, Dr. Christopher Mitkin, Technical Officer of WHO, co-author of Global Elder Abuse Prevalence Study, and joint lead author of the Global Report on Ageism. And our panellists are from 3 of the service trials funded under the National Plan, Gemma Mizrachi from Tasmania Legal Aid, Leslie Merritt from the Elder Abuse Service Trial Relationships Australia in the Northern Territory, and Lee Archer from Justice Connect. Just as the conference will be a hybrid of delegates in person and those experiencing the program virtually, today's forum is a combination of recorded and live presentations. Please use the Q&A panel for any questions or comments throughout the course of this webinar. And as always, address your question to any of our speakers and please be kind and generous in your words. Christopher Mitkin is unable to join us live today, but should you have particular questions for him, we'll endeavour to seek his response and circulate to all participants. And now our first speaker is Russell Westicott, and we're just going to play a pre-recorded video of him.
Hi, I'm Russell Westicott. I'm co-chair of Elder Abuse Action Australia, and I've been involved in the rights of older people for the past decade or so. It's been interesting seeing how things have evolved in the last decade. There's been national elder abuse conferences that were held in 2012 that attracted about 40 people. Elder abuse conferences that have been held in recent years have attracted delegations of around 500 to 600 people. And of course, we're preparing for the 7th National Elder Abuse Conference to be held in Hobart in February 2022. Of course, this will be a different conference because of COVID, and it will be a hybrid conference where some people will be present at the venue and other people will be joining the conference online. But I'm sure, particularly given some of the feedback and some of the enthusiasm in the lead up to the event so far, that we're going to have quite a good showing with the delegation. So over the last 10 years, there's been a lot of change. a lot of change in the community, and also government doing a lot of things, such as the Australian Law Reform Commission report back in 2016, 2017. That report was a watershed moment that highlighted the issues of elder abuse and underscored what we already knew for those of us working in the sector. Elder abuse in Australia is predominantly financial abuse, and it's predominantly perpetrated by people who the older person trusts, and that is quite often family members. So sons, daughters, grandchildren of the older person are often the perpetrators of financial abuse. And family agreements about money, family agreements about granny flats and other real estate issues that go awry because things aren't put in writing. So while we know that elder abuse is often perpetrated within families and within community, we still don't know the exact prevalence of elder abuse in Australia. One of the things that the Commonwealth have committed to is a prevalent study of elder abuse. And I know there's been a lot of work on this over the last couple of years. Of course, from our perspective, from community's perspective, we would like to see the data from the prevalent study released as soon as possible. We would like to understand elder abuse even further. And while there has been some fantastic initiatives that have got started with some pilot projects funded through the Commonwealth Attorney General's Department, about a dozen different pilot projects in different communities around Australia, we want to understand how those pilot projects are going, how they are being evaluated, what the data is showing us in terms of which of those pilot projects are successful, so that we can ensure that all people who are at risk of elder abuse and people who are victims of elder abuse can have access to those sorts of services, the services that work, that we know work through these pilot projects, through the evaluation mechanisms. If in fact the prevalence study shows that about 1 in 10 older people are victims of elder abuse, and that's what we kind of think might be the prevalence in Australia. We won't know, of course, until the prevalence study data is released. But if we go along with World Health Organization guidelines and other similar countries to Australia, if it is in fact 1 in 10 or thereabouts, 4 million older people in Australia, that's 400,000 people each year, could be victims of elder abuse. So we need those sorts of services, the pilot services, to be ramped up, to be statewide and nationwide, so that any person who's victim of elder abuse or at risk of elder abuse can access those services, rather than just small pilot services in particular geographic locations. So there is some urgency from Elder Abuse Action Australia's point of view in ensuring that the evaluation of these pilot projects occurs as expeditiously as possible, and that funding for the ones that work well can get expanded. So elder abuse is a social issue that we've been grappling with as a society, particularly over the last couple of decades. We see on our TVs, particularly with the Royal Commission into Aged Care Quality and Safety, sorts of abuse and neglect in aged care facilities, residential aged care facilities. And while that is shocking, and while it's fantastic that there's been such a good response to that, it is, at the end of the day, only about 7 or 8% of older people who actually end up receiving residential aged care services. The bulk of elder abuse happens in the community and within families. So we need to make sure and not lose our focus on elder abuse in the wider community, to ensure that there are plenty of services in place for older people across the community to be able to access those services. So let's keep the momentum going. It'd be great for as many people as possible to register for the 7th National Elder Abuse Conference to be held in Hobart in February 2022, and have as many people from community actually sharing ideas, putting their voices to lobbying efforts for organisations like EAAA and other national organisations to take to relevant government authorities and government departments, so that we can actually have even a better response, orchestrated response at tackling elder abuse in Australian society. So thank you for participating in today's webinar, and I look forward to people being involved at the conference coming up next February. All the best.
Thanks so much, Russell. I'd now like to introduce Sue Leach, who's the CEO of CODA Tasmania and has been since 2012. Sue is a pharmacist with a health policy background with extensive experience in health and ageing policy. She has a Masters of Ageing from University of Melbourne and has senior management experience in a number of organisations, including the Pharmacy Guild of Australia. She has served on a number of boards over her career, contributing to policy and participating in projects and programs which benefited the community. Sue. Maybe unmute, Sue.
Thanks, Bev. So I'm just going to share my screen. I hope you all can see that. Okay, so what I'm going to talk about today is some results of a survey that has been conducted by the Federation of CODAs across Australia, including CODA Australia. And it was some research that was done in March 2021 by Newgate Research on behalf of the CODA Federation. Now, whilst I'm only going to be talking about a small component of this study, I will give you a little bit of background into the methodology that was used behind the survey, because I think that's important for context as well. And just letting you know that this report is not currently public. You're getting a taster of the data today. It will be officially launched on June 24th. So you keep an eye out for that on our socials through either any of the CODAs or CODA Australia, and you will see a link to the launch of the broader survey. But I am allowed to share with you the data today specifically to do with the elder abuse deep dive. So a little bit about the methodology. Look, it's a much smaller sample size and a different methodology, no doubt, to the prevalence study that we are all awaiting, but it does give us some insights into some of the issues that Russell introduced us to before about trying to get a handle on the prevalence and what people in the community actually do know about elder abuse, which is really important. So it was a 20-minute online survey conducted in March with 2,830 Australians aged over the age of 50 across Australia. And I think it's interesting that this is the age group because from 50 plus, we're capturing potentially family members who may have an older person that they're supporting or know of that may be experiencing elder abuse. So this is the data around the sample size. We do want to point out that this survey was conducted online, and because of that, you will see that the sample size for 80 plus is a smaller sample size, but there were some consideration put into that in the sampling to get some weighting, and also particularly in some of the smaller states and territories such as Tasmania, for example, there was a higher weighting given to make it a representative sample. So this was the definition of elder abuse that was actually given to the participants of the survey so that they could understand what the questions were particularly about. So noting Russell's comments before about the Royal Commission released a special report into elder abuse in the residential aged care setting, this definition was given as an introduction to the question. So I think it was designed to be a framing definition around the questions given. It's interesting to see some of the data that comes out that references aged care later. So what we do know is that a large proportion of elder abuse is actually going underreported. The data from the survey showed that 15% have either experienced elder abuse or know someone who has experienced elder abuse from this survey sample. So 4% of the people surveyed had personally experienced, and 12% knew of someone who had experienced it. Now, I think it's interesting to have a look at this section here, which is of those who were more likely to report who've been personally abused. There's a much higher proportion of people who identified as Aboriginal or Torres Strait Islander peoples. And there is a separate slide about that just following up. I think this section really points out the intersectionality that we see in elder abuse, where you have compounding issues that are experienced by people who report elder abuse. So, for example, those with disability had a higher report of elder abuse. Those who identified as LGBTQIA+, 11% versus 4% who did not. Those who experienced domestic violence in the past 12 months, 30% reported versus 3%. And those who'd experienced the death of a partner or a spouse in the past 12 months were also in this vulnerable group who had experienced elder abuse. I think it's really interesting to note also down the bottom here, a substantial 41% of people had not raised the issue with anyone else. So we're going to look a little bit more into the story behind that in following slides. So 66% of people who identified as Aboriginal or Torres Strait Islander have either experienced elder abuse themselves or know of someone who has experienced, versus 15% of all Australians. 45% said that they had had personal experience of it, and 25% knew of someone else who had experienced it. So I think this is really telling about particular need in this group in the community. Now, there was some further questions that looked at what were the barriers for people seeking seeking help. And clearly at the top here, we have 26% said that the elder abuse came from a very close family member, and that impacted and was a barrier for seeking help. I also think it's really interesting to see some of the personal comments that came through the data. And it's the sort of cases that we do here out in the community. 5% of the survey of people who had identified that they'd experienced abuse said that they removed themselves from the situation and cut ties with the person. 4% acknowledged that the perpetrator was unwell and unaware that they were being abusive. So this is very interesting data. So of the people that knew of someone that had experienced elder abuse, one of the biggest barriers was this experience that they felt that they didn't have a right to try and intervene. So it was not my family or friends, and they felt that they might be impinging on someone else's business. A very sad quote here saying that one of the survey respondents said that they only realised it had probably happened after the person had died. I find this quote quite telling. They were already seeking assistance and legal assistance, and the person commented that they were only emotional support. And I think that that's part of the story that we do need to get out to the community. Being an emotional support is just as important. So our language needs to change in how we're talking about this. It is elder abuse, as Russell mentioned, is a very, very complex issue, and there needs to be support from a whole range of different areas. And if that means that you are an emotional support for something, that should be acknowledged as a very important role. Now, the next slide looks into the different sources of where people went to seek help. And I think this slide shows that we've got a long way to go to raise awareness about the issue of elder abuse. Of those who personally experienced it, 38% spoke to their GP about it. We know we've got a long way to go around education for health professionals in this space, and some of that work has begun, but we've still got much more to do. 34% spoke to a counsellor about it. 11% reported to the nursing home, whether that was care, whether it was abuse happening within the home, we don't know. I think that this is an area that is quite telling. Only 4% of those surveyed actually telephoned a helpline. There was quite a large proportion that fell into the something else category, and this mentions different areas which may well be part of the national plan, the trial sites that are actually being investigated. So I think this is something that we need to explore a little bit more. Of those who knew someone who experienced elder abuse, the second one is quite interesting. I reported it to the nursing home. So this again is quite confusing. Is this related to people who are experiencing elder abuse within residential aged care facilities? Or is that just a place that they felt that they could report it? Again, the helplines are very low in reporting of somewhere that they would go. So I think we need to do a lot more about raising awareness of the helplines that are around the country where people can seek advice. Now, this next slide is for the group of people who had no experience of elder abuse, and I think in itself it is quite interesting. So 58% of people who had no experience of elder abuse said that they would go to the police first. So it was the largest proportion of respondents. Do we actually have police services that are ready to be able to respond in that way is probably another matter that we need to investigate more. And it will be interesting to hear from the panelists about how they feel that work can be continued. I know that there is still a large body of work in the national plan around safeguarding legislation that still needs to be progressed. It does need to be progressed in Tasmania. So I think that's an area to watch. 38% said that they would report it to a nursing home. Again, the aged care facilities feature really highly in responses, but as Russell pointed out, a lot of cases are actually occurring in the community. So there's a communications piece there that I think we need to do. 18% of people that responded who hadn't had an experience of elder abuse said that they would speak to the abusers. So that's an interesting thing, again, that we probably need to explore a little bit further in the work coming out. So thank you for that. It is naturally just a set of questions that were a part of a much larger survey, and I think there's actually some interesting aspects in the rest of the survey that are very relevant to elder abuse. So there's commentary on the impact of COVID, quality of life measures. They were asked about social isolation as well. So I would encourage you, if you have the opportunity, to tune in on the 24th of June to hear more information about the broader survey, because it is just as relevant for elder abuse as this small sample of questions we've covered here. Thank you, Bev.
Thanks so much, Sue. Looking forward to have a look at the full report in a week or so's time. I'd now like to introduce a pre-recorded video from Dr. Christopher Micton. Christopher is a Technical Officer, Demographic Change and Healthy Ageing in the Department of Social Determinants of Health, Division of Healthier Populations in the World Health Organization. As I mentioned earlier, he is the co-author of Global Elder Abuse Prevalence Study and joint lead author of the Global Report on Ageism. His areas of responsibility cover elder abuse, social isolation and loneliness, ageism, and the decade of healthy ageing enabler of data, research and innovation. He is a dual Swiss and American national, and before joining WHO's Demographic Change and Healthy Ageing Unit, he worked for 8.5 years in their Prevention of Violence Unit. He's also worked in academia in the UK and a clinical scientist for the United Kingdom's Ministry of Justice and Department of Health's Dangerous and Severe Personality Disorder Program, as well as the International Committee of the Red Cross. He was educated at the University of Cambridge and McGill University in Montreal. I'd now like to welcome Christopher's video.
Good afternoon, everyone. It's a pleasure and an honor to be contributing to the Walk the Talk Forum Series 221 on driving long-term change in Australia's response to elder abuse on this 221 World Elder Abuse Awareness Day. My name is Chris Micton. I'm leading the World Health Organization's efforts to address elder abuse. I'll be touching on 3 topics in this presentation. First, what WHO has done so far to address elder abuse. Secondly, our plans to step up our efforts to address elder abuse within the decade of healthy aging. And third, the link between elder abuse and ageism. First, though, a brief reminder of some of the key facts about elder abuse. Around 1 in 6 people 60 years and older experience some form of abuse in community settings during the past year. So the problem is really quite widespread. Rates of elder abuse are higher still in institutions such as residential and long-term care facilities. Emerging evidence suggests that elder abuse in both the community and in institutions may have gone up during the COVID-19 pandemic. One study in the US by Chang and Levy suggests it may have gone up by 84% in the community. Elder abuse has a range of devastating consequences, including physical injuries and lasting disabilities, psychological distress and mental health problems such as anxiety and depression, and it leads to an increased risk for institutionalization, hospitalization, morbidity, and mortality. There are a few strategies that appear promising to address elder abuse, but very few of them, almost none, have been demonstrated to be effective in high-quality evaluations. These strategies include professional awareness campaigns to help healthcare workers recognize elder abuse, caregiver support to reduce stress, caregiver training on dementia, and residential care policies to define and improve standards of care. WHO has been addressing elder abuse for some time now, but in a somewhat sporadic way. We have, for instance, published a report called Missing Voices in 2002, which was an 8-country study which tried to get the views of older people on elder abuse. We also published in 2002, along with the International Network on the Prevention of Elder Abuse, the Toronto Declaration on the Global Prevention of Elder Abuse. This called for action aimed at the prevention of elder abuse and introduced what has become one of the standard definitions of elder abuse. In 2011, we published the European Report on Elder Abuse, and then more recently, around 2017-18, Yongji Yon and myself published a series of systematic reviews and meta-analyses on the prevalence of elder abuse, which estimated that 1 in 6 people experienced elder abuse every year. Some of you may be aware the UN recently proclaimed the Decade of Healthy Aging 2021-2030, which WHO is playing a central part. Decade aims to bring together governments, civil society, international agencies, professionals, academia, the media, and the private sector for 10 years of concerted and collaborative action to improve the lives of older people, their families, and communities in which they live in 4 main areas. We're calling these the 4 action areas. The first of these action areas has to do with ageism, which refers to changing how we think, feel, and act towards age and aging. Second main action area is to do with communities, developing communities in ways that foster the abilities of older people. Third action area relates to primary care, delivering integrated care and primary health services responsive to older people. And the fourth action area has to do with long-term care, providing older people who need it with access to long-term care. Recognizing that elder abuse is a topic which cuts across all 4 of these action areas, as part of the decade, WHO has decided to address elder abuse in a more strategic and sustained way. To lay the foundations for this, we started 2 projects, which will both feed into the development of an elder abuse strategy for the rest of the decade of healthy aging. First project is an evidence and gap map. I'll say more about it in a second. And the second is a research project which aims to identify the factors that account for the inadequate global priority of elder abuse and then devise strategies to address them. For those of you who are not familiar with evidence and gap maps, I'll say a few words about them. They are a systematic evidence synthesis product, which displays the available evidence relevant to a specific area, such as elder abuse. They provide a visual and interactive display of the existing evidence, and this is updated on a regular basis. We're hoping to do it every 2 or 3 years for this evidence and gap map on elder abuse. And an important feature is that they say what evidence there is. They don't really say what the evidence says. For that, we'll go on to kind of the second stage of evidence synthesis, which is developing systematic reviews, and things of that sort. The evidence and gap map we're currently working on with a team of about 20 people in 5 different universities around the world will map all the evidence there is on the prevalence of elder abuse in both the community and in institutions, consequences, all the different types of consequences of elder abuse, risk and protective factors for elder abuse, as well as interventions to prevent elder abuse, to detect elder abuse, and to respond to elder abuse. This map will serve several important purposes, be used to identify areas where more research is needed, and then commission the research in a more coordinated and strategic way. Secondly, will help produce higher level evidence synthesis products like reviews of reviews, and perhaps will develop an evidence platform or portal. Will also help develop guidelines on elder abuse. Thirdly, will produce policy briefs on elder abuse to help guide policymakers and decision makers. Fourth, it'll help increase the discoverability and use of the available evidence on elder abuse by policy and decision makers, by program commissioners, and practitioners around the world. It'll help tell implementing agencies in countries which programs are supported by evidence and which are not, where there are evidence-free zones and where there are evidence-rich zones. And the last of these purposes it will serve is to help monitor how the world is doing at addressing elder abuse, particularly the evidence and gap map on the prevalence of elder abuse, and eventually help us to determine if our efforts at driving down elder abuse are actually working. The second project we've got underway is the identification of factors that account for the inadequate global priority of elder abuse. This project is based on a review of the literature and a series of some 26 interviews with experts around the world. Coming to the end of this project, with the process of analyzing, writing up the results, it's still a bit early to give you anything more than an initial glimpse of the findings. For this project, we're using a tried and tested approach developed by Jeremy Schiffman and colleagues, which has been used to understand why other health issues have not received the priority they deserve, such as maternal mortality, early childhood development, urban health, and global surgery. Schiffman defines global priority as the degree to which international and national political leaders actively give attention to an issue and back up that attention with the provision of financial, technical, and human resources that are commensurate with the severity of the issue. And it organizes these possible determinants of global priority into 4 main domains. The first has to do with the strength of the individuals and the organizations concerned with the issue, their abuse in this case. The second has to do with the ways in which those involved with the issue understand it and portray it. The third has to do with the political and policy environments in which the actors operate. And the last has to do with the characteristics of the issue. Are there good global indicators? How much do we know about the severity? Are there effective interventions? And our very preliminary analysis suggests that there are three main factors behind the inadequate political priority of elder abuse. The first has to do with the strength or lack of strength of the global networks concerned with the issue. Second has to do with insufficient funding for this issue. And the third issue I've already touched on is that there are no interventions that have been demonstrated to work in high quality evaluations to address the issue. This is a real problem. If you approach policymakers, approach donors, they'll ask you, well, what can be done about the issue? You want money for this, what can actually be done? And at the moment, we can only say that we really don't know. There are a few promising interventions, but we don't know for sure what works. So this is a real issue. These are just some of the very preliminary findings from this research project. Okay, now I'll say a few words about elder abuse and ageism and our recently launched global report on ageism. During the interviews we conducted for the project looking into the inadequate global priority of elder abuse, it became really clear that people perceive that there are strong links between the two, strong links between elder abuse and ageism. Three sorts mainly. First is that they consider that ageism may be one of the main reasons elder abuse has not received the attention other forms of violence have received, for example, violence against women, violence against children, and that older people are devalued. And that explains why elder abuse doesn't receive the attention and the funding that these other forms of violence receive. Second link is that ageism might be a risk factor for elder abuse. And the third is that elder abuse, at least for some, is sometimes conceived of as an extreme form of ageism. However, in our report, the global report on ageism, we looked into the empirical data on the links between elder abuse and ageism, and we found very little. Just found one study, one empirical study, that suggested that ageism might be a risk factor for elder abuse. So this is clearly one area where a lot more work needs to be done. I'll just say a few words about the main messages of our report. First, we offer a definition of ageism, which we hope will become a consensual definition of ageism. Say that ageism refers to how we think, feel, and act towards others or ourselves based on age. So ageism refers to stereotypes, prejudices, and discrimination towards others and ourselves based on age. Second main message is that ageism is everywhere. 1 in 2 people worldwide have been found to be ageist against older people. And in Europe, there is more ageism against younger people than older people. Ageism also affects us throughout our lifetime. Not just older people who are targets of ageism. Younger people can also be targets of ageism, conceivably other age groups as well. And that ageism interacts with racism, sexism, disability, and actually compounds disadvantage when it interacts in this way. Next main message is that ageism is harmful and it's costly. It has an impact on all aspects of people's health, physical health, their mental health, as well as their social well-being. And it takes a heavy economic toll. A study in the States tried to calculate the cost of ageism over a 1-year period in people about 60 years of age. And they found that annually, 1 in every $7, $63 billion, was spent on healthcare for the 8 most expensive conditions was due to ageism. That's 1 in $7 spent on the 8 most expensive health conditions was due to ageism. So it takes a big economic toll. Next message is that even though the problem is widespread, even though the problem has very serious consequences, we're not powerless in the face of it. There are a number of strategies and interventions that can be implemented to combat ageism. And many of these have been shown to be effective. First strategy, which is based on good evidence, is policy and law can protect the human rights of people and address age discrimination and inequality. Second strategy this report recommends is educational activities, which can transmit knowledge and skills and enhance empathy to reduce ageism. A third strategy recommended by this report is intergenerational contact activities. These can connect people of different generations and help reduce stereotypes, prejudice, and discrimination. The report ends with three main recommendations for action. First is to invest in the three evidence-based strategies to address ageism I just mentioned. The second is to improve data and research, gain a better understanding of ageism, and to develop still more effective interventions and strategies to reduce ageism. And the third is to build a movement to change the narrative around age and aging. You can find more information on the Global Report on Ageism, the report itself, and other communication tools at this website, and you can find more information on elder abuse at this website. Thank you very much for listening. Bye-bye.
Thanks, Christopher. Now we have an opportunity to meet three very patient panelists from the service trials that Russell mentioned earlier. Gemma Mizrachi, Leslie Merritt and Lee Archer. Rather than me read off their bios, what I'd like to ask each of them to do, starting with Leslie, is tell us your job role, the organisation, and just a little snippet of the particular trial your organisation is participating in.
Thank you, Bev. I have the joy and privilege of speaking to you from the wonderful land of the Larrakia people in Darwin, and I've had that joy and privilege for the last 30 years or so. I'm the program manager for the elder abuse service trial pilot that operates in the Northern Territory. The particular service type that is provided through Relationships Australia NT is what our funders call the case management and mediation model. We have an office in Darwin and also an office in Alice Springs where we have staff based.
Great. Thanks, Leslie. Gemma. You're still on mute, I think. Yeah.
I did. Thanks. Hi, and thanks, Bev. I'm Gemma Mizrachi. I'm the coordinator here at the other end of the world, or Australia, down in Tasmania. I'm based in Hobart. I'm the coordinator of Senior Assist, which is part of Tasmania Legal Aid. And we at Senior Assist are one of the specialist elder abuse service trials funded by the Commonwealth Attorney General's Department. Our integrated model has lawyers and case managers providing free legal advice and assistance to older people that are eligible for our service.
Great, thanks, Gemma, and sorry for the mispronunciation of your last name earlier.
That's fine.
Lee, can you talk to us about your service?
Sure. So I'm part of Justice Connect, which is a big community legal centre across New South Wales and Victoria. We do a whole bunch of stuff from homeless law to public interest law to supporting not-for-profits. And I manage the seniors law team across New South Wales and Victoria. The New South Wales team is funded under the service trials to start 3 health justice partnerships. And in Victoria, we have 3 separately funded health justice partnerships as well. So I've got the great benefit of seeing how they work across the states, and we get to do lots of trial and error about how the different programs run. So health justice partnerships are a bit different than the way community legal services usually run. Instead of a clinic model where you might send a lawyer out, you know, once a fortnight to a particular organisation, we embed our lawyers within a health setting. So it might be a community health setting, it might be an acute or a subacute hospital. Our lawyers are there between half a day a week to sometimes 3 days a week. We provide services in legal education, talking to health staff about how to identify and respond to elder abuse. That might be an OT, a nurse, a GP. We have great success with dentists and podiatrists because they often have longer relationships with people that are coming into the community health centre. Who would have thought? Dentists and podiatrists. The second part of what we do is I've got a prop, cup of tea conversation, is because our lawyers are embedded in the health sector and they recognise from the information that they give that we give legal advice about any kind of problem to any health worker to build that kind of trust relationship within the community health sector. And then we do some casework for older people who are experiencing or at risk of experiencing elder abuse. We do AVOs, powers of attorney, it might be family agreements, a whole bunch of stuff, whatever the person needs. We also supplement our program by getting a bit of philanthropy to do some projects so that we can capitalise on our experience. So at the moment we're doing a research co-design project into why people don't use the free tools that are available for them in terms of future planning. And we're working in St Vincent's in Sydney to develop a new elder abuse screening tool because the generalist ones for family violence don't pick up older people. So we're very busy and we're very happy, and we love the health justice partnership model. Our lawyers are the happiest I've ever seen lawyers. So something's working right.
Indeed. Thanks, Lee. So while we're talking to you, what has your service learnt from the trial so far?
It's a really interesting thing to see the two very siloed professions of health and the law working together and understanding the benefits of what each other does. And the glue of social work holding the whole thing together is that it seems to be the exact model to identify and uncover and give language to elder abuse that people might not have been able to name any other way. So we've just been able to see clients that I don't think we would have picked up in ordinary circumstances without the kind of the bolstering of the education and having the referral pathways in there. And what we've learned, I guess, thinking about this question, is the hospitals love it so much, and as they become more mature within the partnership and get more confident, they want to reach out more strategically and get into other health services as well because they can see the benefit for their patients.
Yeah, I mean, I think it's a really important service and a great way of breaking down some of the traditional barriers that may exist for people who might, choose not to go to a lawyer, but equally having a social worker in place to recognise symptoms of elder abuse when perhaps the other staff in the team won't necessarily. Gemma, let's hear from what your service has learnt from the trial.
Well, look, we've learned that elder abuse is complex, and the trauma experienced by older people who have experienced abuse is really complicated by the love people have for usually their adult children, who are often the perpetrators of the abuse. And many clients are caught up in this cycle of abuse and sometimes unable to leave an abusive situation or take legal action. But equally, some clients feel able to. But if we didn't know at the beginning, we know now that the integrated model is the solution, because we have, like the other services, case management delivered by qualified social workers, and their expertise and insights is so critical to our service. So it's wonderful that, people get legal advice, and many of our clients need a lawyer, and need assistance to revoke powers of attorney, recover money, get restraint orders, and some of those key areas of our work. But I think all of our clients need a case manager and really benefit from that, so that it empowers some people to take legal action when they wouldn't have, or to just support those that are so traumatised that at this point anyway that they won't take legal action. So yes, it's certainly been that's my key insight into what I can share about what we've learned here at Senior Assist.
Yeah, I think that's a common story. We did some work late last year with Central Coast New South Wales Legal Service, and it was really interesting talking to both from the legal and a social work perspective, and just how well they work together and the gains that they made. Leslie, what's your service learnt from the trial?
I'd like to build on the learnings that my colleagues Gemma and Lee have had. We also have learned that a multidisciplinary approach is utterly essential. We find that the coordination is really what's lacking for people. Often they might get legal advice, but they can't necessarily put that piece of the jigsaw into with all the other pieces of the jigsaw to sort of move forward on things. So while we don't have lawyers in-house, we certainly work very closely with legal services, and we often find ourselves, we're mainly social workers or working in the community services industry rather than lawyers, but we find that ability to coordinate all the different pieces of the jigsaw is really important for older people. The other thing that we find really important is the capacity to be taking intergenerational, making intergenerational interventions, which is one of the points that the previous speaker talked about. The relationships are so important to people, and the models of intervention that often people are presented with can often be very black and white. A criminal offence has occurred, or it hasn't, and people don't feel like they've got those choices in this situation. They really seem to be wanting to they don't want to break the relationship, but they do want the abuse to stop. So I think our interventions going forward have to be really focused on how do we maintain relationships, but also keep people safe, and that it's not one thing or the other, it has to be both. Yeah,
I think it's a fine point, and one that I think everyone's nodding and thoroughly agrees. So often we're seeing families completely broken down when there may be other solutions that can resolve the issues.
And we're finding that often there's not, it's at this point that, sometimes family issues have been going on forever and ever. And there's all sorts of theories about how that intersects with elder abuse. But I think, I guess often the older person is, I guess the relationships stuff and the healing that people need in their relationships is also a really important part of this this issue.
And it's really difficult to get to that without coordination.
Absolutely, it's impossible, I'd say.
And I've worked in organisations where case managers, and I think someone mentioned it, are often the glue to providing guidance and connection to their client group. And I see this as an incredibly important element for that.
And the silos that we have created in our society, which may well serve professional interests, don't necessarily serve the interests of the older person. And some of the vulnerabilities around elder abuse and ageing are that everything goes so fast. So I'd have to say that one of the other things that we've learned is to try and create space for the people that we're working with to process things at their own pace. That's another really important learning for us.
And Leslie, is there a case study that you can think of that would typify the work in the trial?
There are so many. I guess what I have to say is that people, our service model is meant to be about case management and mediation. So we are always offering the opportunity to bring families together to try and resolve issues. I'd say people don't really understand mediation terribly well. They're quite frightened of it. They don't understand that their understanding of mediation sort of comes from the family law system. And they're not quite sure how mediation can help in this situation. But a case study I can give you of a successful mediation is 3 siblings, 2 of whom had been named by their mother as alternate decision makers, and the mother in this case did have fairly advanced dementia. But the sibling who was doing the actual day-to-day caring of her mother was not a person who was what the sibling named in the her advanced care directive. So I guess we were able to work with the siblings through a mediation process of meeting with them individually and then bringing them together to talk about what's in the best interests of mum. And it was very slow. It probably took about 10 to 15 sessions all up, I guess, by the time we got to the end of it, where they felt that they could work together as a family unit in mum's best interests. Right. So it's a slow and intensive process, is another learning we've had.
Yeah. Yeah. And Lee, is it similar in your experience in terms of that case study environment that typifies your work?
Yeah, so just reflecting, as Leslie was talking about, the amount of time that it takes for people to process it. And one of the things I remember one of our lawyers saying is that being embedded in the hospital means that you can go up and down from the bedside and give pieces of information in small parts so that the person can process it, reflect it, and then go back the next day to sort of build their knowledge and the thinking time that people really need to work out what their next step forward is going to be. And in terms of a case study, I'm thinking of one where a mother and her son, there were 3 children, I think, and the son had permission to have a loan from the mother, which was about $10,000, but he took about $50,000 from the account, and the degree of complexity in the family trying to work out what to do about, the theft of that extra $40,000, and the older woman processing it over weeks and deciding eventually not to do anything about it, and reflecting on Leslie's about the complex family dynamics and sometimes what the price of love and connection is, and in that case $40,000, but just even putting the language around it and the outcome, which might be different to what the lawyers where they think you'll end up and where you actually end up with what the client wants to do.
Yeah, thank you. Gemma, you got? Do you have a case studies that you can share with us this afternoon?
Yeah, sure, Bev. Look, financial abuse, we receive the most amount of referrals involving financial abuse. So I'll share one or that we've seen has that financial element. And what we've seen is cases of adult children convincing their parents to transfer their own homes into the adult child's name. And in one case, it followed the breakdown in the relationship between the mother and her other adult son. But our client's daughter had convinced her mother to be on the title to the property. And they then became joint tenants because of that. The daughter didn't live with her mother and in fact had basically ignored her mother for many months and didn't have anything to do with her, which is what prompted the mother to come to us for help. But randomly, the daughter returned to live with her mother because she was experiencing some difficulties of her own, and she didn't make any financial contributions to the property or contribute to expenses living at home with her mother. So the concerning part of these cases is that the adult children become joint tenants, and then following the principle of survivorship, the whole property passes to them when the parent dies, to the exclusion of other relatives and loved ones that they might have wanted to leave property to. So recently I referred 2 matters involving this kind of elder abuse to a private lawyer, and the private lawyer assisted them to sever that joint tenancy and so that the parties became tenants in common instead, and helped them to change their wills. So that was quite concerning. And it was interesting as well, and it's probably something we're noticing, although we don't have clear data, is that many of our perpetrators are female and daughters, not necessarily male perpetrators all the time. So we'll keep track of that and see if we can report at some point on any trends that might be developing there.
I think that's interesting, Gemma, because I think anecdotally, most people report the male children to being stronger. There's a higher prevalence of male children being the perpetrators, but it's interesting that your data is suggesting something different entirely.
Yeah, and look, I don't know how, we haven't looked at it closely because we haven't had to record that feature, but we are seeing it's not unusual, I guess. Yeah.
Okay, thank you. And I'm interested in, for all of you to answer this question, do you think the trial and what you've learned and talked about a little bit this afternoon, and I know your work is much more layered than the limited time we have to discuss, but do you think there's anything that the trial has revealed that will change other aspects of the way your organisations work outside this trial? I'm going to start with Leslie, who's busy on the thinking music by the looks.
Okay. I guess one of the things that surprised us was that, we learned this very quickly actually, that older people didn't necessarily want to come to our office. They wanted us to go to them. So we've done a lot more outreach than we expected, and we sort of have, now we think, oh, why didn't we think of that before? But I think taking feedback from the people who are using the service has been a really important thing for us in terms of, the pace we work at. And I guess we see we often seem to spend quite a lot of our time reinterpreting or helping people go over information they've received, particularly from large government agencies who sort of want to chunk everything into nice little packages, which are great, but people don't necessarily understand the packages unless somebody's sitting alongside with them. So we're doing quite a lot of what we're calling systems interpretation work. Okay.
And Lee, in your experience, what has your organisation learned from the trial that's going to impact the way you work?
So part of what we did as the trial is started developing a rural HJP as one of our hospitals that was associated with St Vincent's in the Murrumbidgee. So we'd planned that out nicely, and then COVID happened. So we had to do the whole thing remotely. And what's really struck us is the mythology about older people and digital, and that it's impossible to have good outcomes. So the strength of our health justice partnerships meant that we were able to communicate with people who were, out of town, 150 kilometres away, by using our health partners to actually go there and use technology to be able to give people the right kind of advice. And with the new digital witnessing allowances, we were able to get documents signed and do the work that we needed to. So we were able to be much more flexible and innovative on the fly than we thought we probably would have been doing everything face to face.
I mean, there are challenges around that, of course, in terms of privacy and
Absolutely.
but I think the advantages, certainly given the COVID environment, lots of, dare I say, lots of organisations have pivoted to trying to get the same outcome for their clients, but using different ways of working.
Yeah.
Which I think is what you're saying as well, Leslie, in terms of not necessarily assuming that people are going to want to come and chat to you. You've got to go to them and meet where they want to be met.
But I would also reinforce Lee's point. We found that we only had a mercifully short lockdown in the NT, only 6 weeks. And we did find in that time that people were more than happy to keep in contact with us by the phone, whereas, we're quite happy to adapt and much more adaptable than what we had thought. So we were extremely busy over the COVID lockdown time when we were working from home.
Yeah, thanks, Leslie. Russell.
I just noticed a question in the chat from Kate Yeoman, and she asks, how long are these pilot programs running for? Gemma, do you want to answer that?
Sure. So these pilots have been funded for 3 years, and they're due to end on the 30th of June 2022. We're all hopeful that they'll be funded again, given the success of the services to date. But I'll just quickly add to what Leslie said, is that our experience as well is that clients are really appreciative of our outreach, and we travel to clients often to their homes, to hospitals, aged care facilities, or another safe place or a community centre. And that's something that I think with this type of community or client group is really effective.
Sorry, Russell, go on.
Yeah. No, I was just going to say, but to that point, I think that it's vital that we understand the successes of these pilot projects so that they can be replicated and rolled out on a much larger scale. I think it's important, if we're looking, as I was saying in my introductory piece, if in fact 1 in 10 people are victims of elder abuse in the Australian context, that's almost 400,000 people a year. So we want to ensure that there are services that can cope with 400,000 people being given access to those services. So that's the next step, I think.
Yeah, which is a kind of perfect segue into my next point of discussion, which is, where to from here. And to Russell's point, we are going to have an ageing population for quite some years, and we do need to do collectively perhaps a better job in responding to elder abuse. And to Christopher's point, the ageism perhaps that drives the discrimination towards older people is also something that needs to be addressed, and it's certainly something Sue raised in her presentation. So what do you think needs to happen from this point on with these trials? Do they need to expand? Is it something that are there changes that need to happen in the models that you've been working with in these trials? Lee, do you think there are further changes required?
I think that it's a high intensity model for the HJPs, and I think that the value of educating the health staff has to be really strengthened. That's where I think a lot of the gains are, because you're able to deliver casework to a few people in the model, but really bringing the health sector alongside you to understand what elder abuse is and to have language around it, I think is one of the key drivers.
Yeah. No, agree completely. Gemma, do you have any thoughts on where to from here and what may need to change?
I think And we're considering how we could expand if we were funded again, so that we can provide more representation to people in court for restraint orders, and even, consider increasing the scope so that we could provide more civil assistance to people without having, because at the moment we would have to refer people to a private lawyer to pursue a civil claim or go to the Supreme Court. But if we had carriage of it for longer, perhaps that would improve access to justice.
Okay. Yep. Leslie, do you have any thoughts?
I'd like older people to have a say in defining what justice means for them, and that the systems, can be responsive that way. I think that there's a whole lot of unexplored link. I came from working in the domestic and family violence sector, so I had been more used to working with women and children before I came into this role. And there's many similarities, but there's also a whole lot of differences. So I think that I haven't really found a way to articulate those two things together as yet. So I think it would be good to make those linkages stronger and to think some of that through about whether elder abuse is something different to domestic and family violence, or it's the same, and if so, why, or some of that philosophical stuff. Because I think our community is struggling with that.
And whilst I'm not going to directly answer Stephanie's question, hers is about language around elder abuse, or around abuse, and particularly elder abuse, and what older people think of that term, and do they engage and respond to it. I think is a pretty interesting topic for us to take on. I'm expecting it'll be taken on in the conference. And I'm just going to say it's 4:23 and we're due to finish at 4:30. And I know there are a range of questions in the Q&A, which we are undoubtedly not going to get to. So we'll commit to providing some responses to those. But I'm aware, Sue, do you want to just add to answer one of the questions in the Q&A?
Yes, certainly. There was a question that came through specifically around GP training. And I know that that's something that in Tasmania has certainly been factored into some work that they've been doing around awareness raising. And I think it reflects to the data that came through in the State of the Older Nation, where people, quite a lot of people said that they would talk to their GP about it. One of the issues we do know that GP practices are very, very busy, and being able to deal with that in an appropriate way is a challenge. And so there is some work underway with the Tasmanian government to get some specific training in place for GPs and GP practices. So that's one area I think is certainly needed. And look, I'm very interested in the health justice trials to see what they deliver as well, to see whether that is something that could potentially work within the GP land as well. The other question that I noticed in the Q&A was around the low awareness of the helplines. And helplines are certainly a really good place for people to start to get information, but they're clearly not known about a lot. The Tasmanian government has got a new campaign that asks things in a slightly different way. So there's very much a focus on addressing that doubt that might be in people's minds about whether it might be elder abuse, and saying that it is actually okay to ask the question about it. So trying to shift the conversation about being more open into what can go on from that if you get that kernel of doubt, what to do next. So I think that's going to be really interesting to see how that plays out. They are doing some more intensive work for their website, which will be case studies. So I think the stories are very powerful for people to be able to identify as well. So I think that that's a really important component of the campaign that is goes beyond the media that is paid media. And look, we really hope that at the conference that we can have a strong focus on hearing those personal stories of people. And I know that we're in discussions with the Tasmania Department about getting access to some of the videos that they have produced as part of that campaign, which are case-based scenarios as well, and hopefully they will be at the national conference so we can share them with a broader audience.
Thanks, Sue. Just a quick 30-second wrap. Russell, anything else you'd like to add before we head towards 4:30?
No, I think it's been a really interesting discussion. As I was pointing out in my opening remarks, the last 10 years, we seem to have galvanised a lot of different people, a lot of different sectors into a response around elder abuse. We've got to this point now where we've got pilot projects being funded, a prevalence study, and I think that we need to keep the momentum going. And I would just encourage people to remain engaged, to go to the conference or register for the conference, participate in discussions like this, because I think the problem is so big that it's going to take a seismic shift and a generational piece of reflection so that we can counter elder abuse in the years ahead.
Thanks, Russell. Leslie?
In our experience, while financial abuse is the easiest thing to talk about in some ways because it's concrete and it's tangible, and we could look at bank statements and all those things, it's rarely happening on its own.
Yeah.
Is probably what I would just clarify for people, because we
Great comment. Thank you. Lee?
I think there's a bit of work for government to do in countering some of the dreadful ageism that arose during COVID. I think that we took a couple of backward steps in the way that we talked about the dispensability of both people with a disability and older people. So I think there's a lot of responsibility on them to actually counter that.
Yeah. We could have a whole topic just on that, I reckon, Lee. Gemma, just a quick wrap, please.
I think actually the research Sue Leach was talking about highlights that while we're doing community legal education and other providers are too, clearly we haven't reached the majority of people who are actually affected, and so much more needs to be done. And then, of course, we need to service those people, but it's a process in that you raise awareness slowly and then increase the services too. So
it's a 10-year plus road we're on, and I'm not quite sure 10 years from now maybe. But look, I think thank you very much to all of you for giving up some time on this very important day of recognition, reflection, remembrance. There's clearly much work to be done. I hope that you'll join us in the next forum on the 1st of October with more information to come out. Early bird registrations are open for the conference, so we encourage you all to register, and hopefully we'll see you all in person, and if not as a virtual in Hobart next year. And we will respond to those questions and circulate those to all the participants. Thank you so much, and good afternoon, everyone.